Hi there. Danielle, I'm Julie.
Hi.
Nice to meet you. I'm going to be the nurse that's going to be taking care of you today, okay?
Okay.
I'm going to provide privacy. I'm going to be here for about 20 minutes. I'm going to wash my hands real quick, and we're just going to do kind of listening to your heart, checking your heart and your lungs and your belly and make sure everything is the way it should be today, okay? Does that
Okay,
work?
sounds
Great.
good.
Okay. So I'm going to go over here. I'm going to do my hand hygiene. I'm getting all ready. And then at this point, I would sit and do a blood pressure with the patient. So I'm going to do your blood pressure, Danielle. And I'm not going to really do this, guys, because we're just going to talk through it. I would put the cuff on, make sure that the brachial artery arrow goes down by the brachial artery. The cuff is the right size. I do the two-step method where I have the cuff on and I'm feeling the pulse. And when I lose the pulse, I look at the number that's on the cuff. I deflate it. And when I go back to take the actual blood pressure, I'm going about 30 points above where I lost the pulse feeling. So I'm going to do the blood pressure, first sound and the last sound that I hear. We're all done with that. Wonderful. You have great blood pressure, Danielle.
Thank you.
The next I would probably have, I'm going to be doing your respiratory rate. In real life, I'm probably not going to tell a patient that because they might be real conscious and then breathe abnormally. When it's you guys in checkoff, you can either have the patient you're going to say that you're going to watch them do the breathe normally and have them breathe normally for a full minute. You can either do that and just watch, or you can have your hand on their chest and then just feel the chest going up and down. I'm going to be counting along with you to make sure that we get an accurate reading for them. We've got the respiratory rate, everything is good there. So now we're going to move to inspecting and looking at everything that we need to look at. A lot we observe when we first come in. So Danielle, I can see that your facial expression is relaxed. I don't see any cyanosis or blueness around your mouth. I don't see you grimacing or having pursed lip breathing that would tell me you're in distress. I don't see your shoulders lifting or your neck looking full. We'd want to watch to see if the person is leaning over in the tripod position. That would show they probably would have difficulty breathing. Anything at all that gives me the impression that the person is in some type of respiratory distress. I'm making a mental note of all of those things. And once I'm done looking, I would have, if you're okay taking your sleeves, your sweater off. Good. So now I've looked at the patient. So now, Danielle, I'm going to just feel along your skin, on your arms and your legs, and I'm going to check your pulses while we're doing that too, okay? My hands are a little cold, so I apologize. Just do this again because I think that's real hand hygiene. And that's soap. Okay. So we're going to check the carotid pulse. I'm going to feel right down here. And everything feels good. And then the other side, we're just doing one at a time. Good. We're going to come back to that later and auscultate. Otherwise, I'm then going to feel the temperature of the skin, the color of the skin. Does it look bluish? Is she diaphoretic? Is it cold? Can I feel everything here? Can I feel the brachial pulses? Yep, they feel good. +2 bilaterally. I'm feeling the radial pulses. And what I would do here, guys, is I'm going to have you feel the radial pulse to compare, but this would also be a good time to do this for 30 seconds, and I will come on the other side for 30 seconds, and we're going to count and just make sure we get the same number while we're here, okay? Then I'll move to check capillary refill since I'm right here. I'm going to press on the fingertips. They should turn from pink to white and back to pink again within a few seconds. That all looks good. I would again then keep going down to the lower extremities. We would have the person have like shorts on or have the bare skin normally. And I'm going to feel, and I'm going to press to see if there's any, oops, sorry. I'm going to press to see if there's any edema. Sorry. Press to see if there's edema. Again, I'd be doing this on both of the legs because I want to compare. I can do the popliteal pulse here. I can do the dorsalis pedis pulse at the same time on the medial aspect of behind the ankle. And then we talked, posterior tibial. And then dorsalis pedis, as I mentioned in class, kind of put your fingers like this, bring them up, and you should be able to feel that on top of the foot. Again, all of those are being done bilaterally at the same time. We're checking for symmetry. Normal number would be +2, and her pulses are all good, so that would be +2. Good. Okay. So we have checked all the skin, face, extremities. I will be looking for palpation next. We're gonna look and I'm gonna feel on your anterior and posterior chest to make sure that I'm not feeling any lumps or masses or feel crepitus. Crepitus is when there's like a popping, either sound or feel where there's air trapped under the tissue, under the skin. So we'll feel for that. And then when I come around to your back, I'm gonna check your chest expansion. So, okay. Feel, we're going to take our 4 fingers, go along the chest wall. There's not any lumps or masses. I don't feel any popping. Whoops, I'm right in the way of the camera. And the same thing in the back. And then while I'm back here, let's see, I'm going to put, yep, we're going to go a little bit like that. I'm going to check Danielle's chest expansion and make sure that it is symmetrical. So I want to look to see. Okay, I'm gonna put my fingers about T9 and T10, my thumbs in here, my hands here, and I'm gonna have Danielle take a deep breath in and out. There's up and down. And do one more for me. Good. And what should happen is my hands should move just a few millimeters, my thumbs should move, and they should be moving both in the same direction at the same rate and the same distance. That means that the lungs are functioning in the same way. So we're all done with that. And while we've got you here, I think I'll keep you sideways this way for the camera. I'm going to also check to make sure that the ratio of her anterior to posterior chest is about half the width of the transverse chest. So it should be a 1-to-2 ratio. So I'm going to go like this and see about how far it is front to back. That's called the AP, anterior to posterior. And then I'll have you spin toward me. And that should be about half of the distance of her transverse chest, which it is, because this is transverse across. So I would say her AP to transverse chest ratio is 1-to-2. That's a good thing. We wouldn't want it to be 1-to-1. That would mean the patient has barrel chest. Usually patients with some respiratory issues could be like that. So we did the palpating with the respiratory system. Next, I will listen to the breath sounds. For the sake of the check off, I'm going to make sure there are 4 on each side anteriorly, and then I'll have her spin on the back, and I'll do 9 on each side. So I put the stethoscope. We're going to pretend this is, I'll just do it. We're going to make sure we're using the diaphragm, tap to make sure that's there. I'm going to start above the clavicle. So I'm listening to sounds near the trachea, and I'm going to have Danielle take breath in. Each time, I'm going to say, each time you feel me touch the stethoscope to your skin, I want you to take a breath with your mouth open in and out, okay? Here we go. Good. And then I'm going to do a serpentine pattern. Here's number 2. Good, and I should be hearing broncho-vesicular sounds, just air moving in and out. Good, and then I would kind of go down to the side. Good. Good. And then I'm going to do you spin all the way around and we'll do the posterior. So on here, I want to have 9 on each side. And again, remember that the lungs are going in this direction. You want to hit the tissue, not the scapula. So we're going to start at the top again. And I'm going to have you take a breath in and out. Good. Serpentine. There's 2, 3. If you need me to take a break, let me know, Danielle. Raise your hand. 4, 5, 6. By the time we're done, down to 6 or 7, we should be near the bottom of the rib cage. And then we're going to wing out for 8 and 9. That's 9. Good. With a real patient, we're always going to go under the shirt on skin to skin. Otherwise, even when I'm listening here, it sounded kind of rub-y, and that's because of the fabric on the clothing. So with a real patient, we'll always go skin to skin. Okay, we can face forward again. We did everything there. And now we're going to move from the respiratory system to the cardiac system. We already did all the pulses and the capillary refill. I am going to auscultate the carotid pulses, and then I'm going to auscultate her heart. So when we auscultate the carotid artery, we will always use the bell. We are listening for bruits, which is turbulence in the blood flow through the carotid artery. So again, I'm just going to listen. She's just going to breathe normal. Good. Good. And a bruit would sound like a swishing sound, meaning that the blood is having trouble flowing. I don't hear any swooshing sounds at all. I'm going to now listen to the heart first with the diaphragm. So let me go back. Good. And I'm going to tell you where I am and what I'm listening to. I'm going to be at the second intercostal space. There's the clavicle, rib 1, rib 2, and then the space in between 2 and 3 is called the second intercostal space. And I'm to the right of the sternum. So we call that the right sternal border. So second intercostal space, right sternal border. With my diaphragm, I'm listening to the aortic valve. And I'm listening for S1 and S2. And as with all of these things, I'm paying attention to the rate, meaning how fast or slow is the heart going, and the rhythm, how regular is it? Is it lub-dub, which is S1, S2, or is it lub-dub-dub, lub-dub, lub-swoosh, all these abnormalities. So listening for S1 and S2. This is where I hear the aortic valve. I'm going to go straight across to the other side of the chest, still at the second intercostal space, only on the left sternal border, and I'm listening to the pulmonic valve. Again, I'm listening there. I should really be holding it like this to be most accurate. And I'm listening for S1 and S2, lub-dub, lub-dub. I hear that well. I'm going to go down one more rib in between the third and fourth space. We call that the third intercostal space. And I'm listening at Erb's point, ERB. This is the best place to hear both the aortic and pulmonary valves. Now I'm going down to the fourth intercostal space, still all along that right sternal border between ribs 4 and 5. I'm listening to the tricuspid valve. Good, S1 and S2. No murmurs. The rate and the rhythm are regular. And then I'm going to go kind of under the breast in the mid-clavicular line. It's kind of the nipple line. And go after the fifth rib, so fifth intercostal space. And this is called the apex of the heart, called the point of maximum impulse. It's the best place to hear the mitral valve. And this is where you listen for a full minute to really get a good assessment of how the heart sounds. So in the checkoff, we'll listen for a full minute. And we've got that all done. And we're going to do the exact same thing now, this time with the bell. And the second time around again, we know where the placement is. There's aortic, pulmonic, Erb's, tricuspid, mitral. So listen to all of those things. Good. So we've got the respiratory system and the cardiac, the heart part all listened to. Now what I'd like to have you do, Danielle, is you're gonna magically turn into this person in the bed, and I am going to assess for JVD, and I'm gonna do an abdominal assessment. Danielle has morphed into this, well, beautiful, attractive lady over here, very relaxed, still Danielle. And I am going to assess for JVD, for jugular venous distension. I want to make sure we can see everything okay in there. It might be easier if you hold it a little bit. When we're assessing JVD, we want the head of the bed to be 30 to 45 degrees at an incline, so not flat, not all the way up. We want the pillow out from under the patient's head. There we go. Thank you, Danielle. And then I am going to get down to where Danielle's neck is, and I'm going to be on the right-hand side. I'm on the right-hand side because the blood goes into the right side of the heart. If somebody has trouble, the blood will most likely back up into the right jugular vein. So I'm looking to see if this vein right here is distended. And it's best to do that if I say, Danielle, can you turn your head a little bit that way? And she can. And then if I've got a pen light with me too, that works, that helps. And I'm looking at the jugular vein here, and if it's not popping out, if it's not distended, then we would say the patient is negative. They have negative JVD, which is what we want. If it's bulging at any point, then we'd say the patient is positive for JVD. That would tell us we need to do some more looking into their cardiac system, because that isn't what we want for them. So we check for JVD. Thank you very much, Danielle. And now the last thing I'm going to do is assess your abdomen. As you noticed, you guys, with all of the other assessments, we inspected first, and then we palpated, and then we auscultated at the end. It's different with the abdomen. We don't want to jostle whatever thing is going on or mix up anything that's moving through the intestines. So we're first going to ask if the patient's in pain anywhere or having any tenderness in the belly, because the last thing that I want to do is start pressing real hard on something that's going to cause pain for the patient. Patient says she feels great. Wonderful. Okay, so I'm first just going to get a look at the abdomen. We're going to lift this gown up if that's okay with you. Looks like this patient has an ostomy, which is a surprise. I would kind of get down at the level of the patient's belly and take a look across. I'm looking to see what the contour of the belly is. Is it flat? Is it rounded? Is anything look distended? Are there any scars? This is a stoma from a colostomy. So is the umbilicus midline? I'm just making observations. Did they have a C-section? Anything at all that might be abnormal? And then I'm going to put my stethoscope on your belly, Danielle, okay? So for this, guys, we're not counting, we're just listening. All we care about is I'm trying to hear bowel sounds, borygamy, in the abdomen to make sure that she is digesting everything and that the bowels are active. So I'm going to use the diaphragm of the stethoscope. I'm going to start in the right lower quadrant because that's where our anatomy starts with the large intestines. And I'm just going to listen down here. And it might take up to 2 minutes. It might be 30 seconds, but I'm listening for that gurgling sound. And once I hear the gurgling sound, that tells me that part of the bowel is moving. I can move up, and we're going to move clockwise around the abdomen. So we're going to go to start with the right lower. I'm going to the right upper quadrant. I hear a bowel sound. I move over. We hear bowel sounds. And I can finally end down here. Wonderful. So making sure that you're listening. If it was a ton of activity in there, we would call that hyperactive. If there was minimal activity, we'd call it hypoactive. If there were no sounds, you'd say absent. Most of the no sounds would be concerning unless they just got done with some surgery and their bowel hasn't woken back up yet. Next, if it's okay with you, Danielle, I'm going to press just on your abdomen and you let me know if anything feels tender. No problem. Good. So I'm going to take my 4 fingers, lay them flat, and I'm going to work in a circular motion. Down here, starting in the right lower, going to the right upper. This body doesn't move very much, obviously. A real person's belly would. Left upper, left lower. Good. And everything seems wonderful. So, Danielle, I am all done with my assessment. Do you have any questions or concerns for me? And she's going to say, no, I'm not worried about a thing. Wonderful. So what I'm going to do before I leave is I'm going to make sure that I put the bed all the way down. Whoop, that's going up. All the way down is in the lowest position. I would put any side rails up that need to be up. I'm going to make sure that the call light is within reach, that the table is alongside, that her phone is nearby, everything is reachable for her. And she doesn't have any questions. I've asked her about that. I've done any patient teaching I needed. I would come back over, do my hand hygiene, and then thank her for her time and double check that I didn't miss anything. I think
yeah,
everything.
just the subjective data and locus of control.
Thank you. Sorry. So when you first come in and you ask them to say their name and date of birth, make sure you're assessing if they are alert and oriented ×4. So are they alert and oriented to person, place, time, and situation? Meaning I would say, Danielle, can you give me your name and date of birth? She would. I can ask her if she knows where she is. Yes, I'm at the hospital. Do you know what season it is? Yes, it's fall. And do you know why you're here? Yep, I just came in yesterday with abdominal surgery. And the reason that we ask if level of consciousness or if they're alert and oriented at the beginning of the visit is because especially if you have respiratory problems, if you're not getting perfused or getting enough blood and oxygen up to the brain, it can make somebody foggy and confused. So we want to make sure that they are mentally sharp. Thank you for that reminder. That's it. Thanks.